Hi, Daniel here from Australian Imaging, just with one of our good clients, Dr. Agim Hymer from First Bite Dental. Hello Agim, how are you?
I'm good, thank you.
Agim's here to show us today a typical case that he would see in the practice of a impacted canine, and this is one of his orthodontic patients. And Agim just wants to talk a little bit about where the 3D has been useful in diagnosing this common trait in orthodontics and how you use it again.
Well, it's in the good old days we had the slob rule, same lingual opposite buccal, and that's how we used to work out where the canines are. Whereas since 3D's come into dentistry, and I've had it for quite a while, to me it's just a normal part of orthodontics for impacted canines. I do my own surgery. Sometimes I do refer the canines because they're very difficult to do, especially for canine extractions. And so I still take the image and I give the image to the oral surgeon, and he's very grateful because sometimes these canines can form the floor of the sinus.
Right.
So for me, doing this image, it helps me work out where is the canine, the difficulty of the surgery, and also the timing of the surgery. That's sometimes the most important part. So this is a difficult surgical technique because the canine is placed palatally. And those of you who do your own surgery, when it's palatally placed, you can see it's palatally placed there and very high up. So that's the dilemma with this tooth, is the position. So I had to time it and I had to wait for it to come down a bit further before I did go in there and expose it. And I made sure I opened up the space enough to make the exposure a bit easier. It still wasn't an easy one, but it was easier than if I'd gone in there blind trying to do it. You don't really know where they are. But that's how I was trained. That's how we always used to do it, because 30 years ago we didn't have this kind of technology.
Sure, given obviously having that preparation on the first outset before you even approach the surgical site, in your mind you already know the path that you're actually going to take. So it's a lot easier to see with 3D, would you agree?
Exactly. And you cause less damage, you cause less problems, and the patient's aware of what you're going to do as well. And we charge for the x-rays. We don't give it as part of the orthodontic package. It's a separate fee.
Yep.
Just like the surgery is a separate fee.
And how do you find that is taken by the patient? Are they happy to pay in most instances? Not really much of a problem at all?
No one ever questions it. Like, there's not a question.
I didn't think so.
Yeah, there's not a question. It's just that's what we do, and that's what they need to do.
Yep.
To be able to do it. We'll put it this way: if I don't take the X-ray, the surgeon will take the X-ray. Someone's got to take the X-ray, so I might as well take it myself.
Thank you very much for showing us that interesting case here today. Again, thank you for your time.